In this video, we will discuss the clinical considerations in prescribing antimicrobial drugs. We will examine 4 criteria used to evaluate antimicrobials, including their spectrum of action, their efficacy, the route of administration, and the safety and side effects. The characteristics of the ideal antimicrobial agent is one that is readily available, inexpensive, chemically stable, easily administered, non-toxic and non-allergenic, and is selectively toxic against a wide range of pathogens. There are not any antimicrobial agents that meet all of these criteria. Therefore, the best drug for the given situation must be selected with regards to a set of criteria. The best antimicrobial agent is selected based on its spectrum of action, its efficacy, its route of administration, and its safety and side effects. Each antimicrobial agent has a particular range of activity, meaning that each time it is used, it works against the same type or types of microorganisms. The range of microorganisms against which an antimicrobial drugs work is known as its spectrum. Drugs that are referred to as narrow-spectrum drugs are effective on a small range of cell types. Examples of narrow-spectrum drugs are isoniazid and ethambutol, which are only effective against cells that contain mycolic acids, such as mycobacteria, or the drug bacitracin, which is only effective against gram-positive bacteria. Broad-spectrum drugs are effective against many different cell types. Examples include drugs like the tetracyclines, which are active against gram-positive bacteria, gram-negative bacteria, and mycoplasmas. Broad-spectrum drugs can lead to secondary infections because they not only kill the pathogen causing the infection, but also the members of the normal flora. The normal flora typically act to protect us from opportunistic pathogens such as Candida albicans and Clostridium difficile. When broad-spectrum drugs inhibit the normal flora, these organisms are allowed to flourish. We will encounter these 2 opportunistic pathogens at a later point in this discussion as well. The efficacy of an antimicrobial may be assessed using a variety of tests, including the diffusion susceptibility test, the minimum inhibitory concentration test, and the minimum bactericidal test. The diffusion susceptibility test is also known as the Kirby-Bauer test. To perform this test, a Petri plate containing an agar medium is inoculated such that the bacteria are evenly placed over the entire surface of the medium. Filter discs impregnated with known concentrations of antimicrobial drugs are then placed on the agar plate, and the plate is incubated. The media used is designated to allow the drug to diffuse into the media. If the antimicrobial agent is capable of inhibiting the microorganism, a zone of inhibition will form around the disc. A zone of inhibition is a clear zone where the bacteria are not growing. The zone of inhibition is then measured and compared to a standard table for that drug and concentration. The result is then classified as sensitive, intermediate, or resistant. The minimum inhibitory concentration test is performed to determine the smallest concentration of the drug needed to inhibit the growth of a pathogen. The minimum inhibitory concentration can be determined using a broth dilution test, as seen in the image on the left. A broth dilution test is performed by introducing a standardized amount of bacteria to serial dilutions of antimicrobial agents present in the test tubes. Following incubation, growth is assessed by turbidity. The minimum inhibitory concentration is the lowest concentration in which no growth is present. In the case of the figure, it would be the 5th test tube from the left. The minimum inhibitory concentration test does not allow one to determine if the concentration is bacteriostatic or bactericidal. Several of the lowest concentrations showing no growth will be taken and utilized for the minimum bactericidal test. We will discuss it shortly. The image on the right shows a test known as the E-test. It combines the minimum inhibitory concentration test with the diffusion susceptibility test. The plastic strip contains a gradient of antibiotic concentrations. The minimum inhibitory concentration can be read from a scale printed on the strip. The point at which the zone of inhibition intersects the scale printed on the strip is the minimum inhibitory concentration. Now let's consider the minimum bactericidal concentration test. As I previously stated, several of the test tubes from the minimum inhibitory test will be used to determine the minimum bactericidal concentration, which is the lowest concentration of an antibiotic that is required to kill all of the microbes rather than just inhibit it. The samples are used to inoculate drug-free media in Petri plates. Following incubation, any concentrations that were simply bacteriostatic will show growth. The lowest concentration in which no growth occurs is the minimum bactericidal concentration. It is important to determine the minimum inhibitory concentration and the minimum bactericidal concentration because it allows healthcare personnel to avoid excessive or incorrect use of antibiotics and minimizes the likelihood of toxic reactions that larger than necessary doses could cause. Healthcare personnel must also consider the route of administration for the particular drug and the site of the infection. External infections such as dermatophyte infections or skin infections may be treated with drugs that are applied topically. Internal infections may be treated with oral medications or medications that are administered parenterally by intramuscular injection or intravenously. Each of the routes poses advantages and disadvantages. Orally administered drugs do not require any needles and they can be self-administered by the patient. However, the dosage achieved in the body is lower than that of either the intramuscular or intravenous administration. Another major disadvantage is that the patient does not always take the medication as prescribed. Intramuscular injection is accomplished using a hypodermic needle. The drug is delivered into the muscle tissue and slowly diffuses into the capillaries of the muscle. The drug does not reach the concentrations achieved with intravenous administration. Intravenous administration is accomplished by directly delivering the drug to the blood. The initial concentration will be very high but will quickly diminish unless the drug is administered continuously. In addition to the route, healthcare professionals must also consider how the drug is distributed into the tissues by the blood. Drugs that are quickly eliminated by the kidneys will not have sufficient time in the bloodstream to reach organs such as the heart. However, the same drug would have adequate time to help eliminate a bladder infection. Infections involving the brain and spinal cord are some of the most difficult to treat because of the presence of the blood-brain barrier. The blood-brain barrier prevents many antimicrobial drugs from being able to reach those particular organs. Healthcare professionals must also consider the side effects of drugs before administering them to a patient. Side effects can be classified into three groups. The first type of side effect is toxicity. We began this section by suggesting that antimicrobial drugs should be selectively toxic to the pathogen, meaning that it should kill the pathogen without harming the patient. As we observed throughout our survey of commonly used antimicrobials, a number of them have had toxic side effects. Drugs have been observed to cause toxicity to a number of organs, including liver damage, kidney damage, hearing impairment, and damage to developing fetuses or embryos. Many of the toxic effects are not well understood. Another form of side effect is allergic reactions, which occur when the drug is recognized as an antigen and acts to stimulate an allergic immune response. Those of most concern are reactions that lead to anaphylactic shock, which can be life-threatening. Each year, approximately 0.1% of Americans experience anaphylactic reactions to penicillins, resulting in about 300 deaths annually. Allergic reactions have been documented in response to every major type of antimicrobial agent. However, penicillins account for the greatest number of allergic reactions, followed by the sulfonamides. Administration of antimicrobial agents may also cause a disruption of the normal flora. The normal flora consists mostly of harmless or beneficial bacteria. A small number of the normal flora can act as opportunistic pathogens. When a patient is administered broad-spectrum drugs, they not only kill the pathogen, but also members of the normal flora. Resistant microbes begin to overgrow and cause disease when the normal flora are not present to outcompete them. Candida albicans is one such opportunistic pathogen, which can cause yeast infections in women who have taken a broad-spectrum antibiotic. Another problematic organism is Clostridium difficile. Clostridium difficile is an endospore-forming bacteria that can resist broad-spectrum antibiotics like the tetracyclines, clindamycin, penicillins, and cephalosporins. When the normal flora is reduced to a point where it cannot compete with the Clostridium difficile, the bacterium begins to flourish and secretes toxins that are damaging to the lining of the colon and causes a condition known as antibiotic-associated colitis, also known as pseudomembranous colitis. These types of infections are known as superinfections.